I want to thank you all for attending today's 2024-25 Alvin F. Poussaint, MD Lectureship. And we are both online and here live in Gordon Hall. I'm delighted that today we have Dean George Daly joining us and his being here to extend his welcoming remarks and tell us a little bit about the history of this lectureship.
Thank you. Yes. Let's see, does this work? Oh, very good. Okay. Well, thank you, Joan. Good afternoon, everyone. It's great to see so many colleagues and friends here for this event, the Alvin F. Poussaint Visiting Lecture. Now, this year's lectureship, I think, has a special poignancy, given that Dr. Poussaint passed just a little less than 2 months ago. And Tina, we're honored to have you here today. This is a particularly special event. And I hope that you will take comfort in all of the folks who are here expressing their love for Dr. Poussaint and for you. So the lectureship is in honor of really one of the legendary figures at Harvard Medical School. And I'm going to share a few words about Dr. Poussaint's amazing legacy for those of you who are not as familiar. Alvin Francis Poussaint was a professor of psychiatry at Harvard Medical School. He was an influential psychiatrist and a scholar, and he was an advocate for equitable access and opportunity for students. And he served as the faculty associate dean for student affairs at Harvard Medical School until his retirement in 2019. Now, importantly, he was the founding director of the Office of Recruitment and Multicultural Affairs in 1969. And I remember that we had a remarkable celebration of the 50th anniversary. He was the author of numerous books on child psychiatry. He had a particular focus on the raising of African-American children. He had tremendous influence through his scholarship, through his advocacy, and through his support of television programming, which sent positive messages. Now, before all that, and remarkably, in 1965, Dr. Poussaint served as the Southern Field Director of the Medical Committee on Human Rights. It was in this capacity that Dr. Poussaint participated in the historic 54-mile march from Selma to Montgomery. Dr. Poussaint famously risked his life in the process of coordinating and administrating medical care to protesters, many of whom were attacked and beaten while marching. So Dr. Poussaint was and continues to be an example for us all for how we might advance the cause of health equity and dignity for all people. And I think it's very, very, very timely that we remember Dr. Poussaint, given what we see happening in our country today. Dr. Poussaint's voice, his actions, they carry tremendous power throughout his career. So it is incumbent upon us all to carry that passion forward through our unwavering commitment to justice, equality, and health and well-being for all. The Alvin F. Poussaint Visiting Lecture Fund at Harvard Medical School was established in 2004 with an inaugural gift from Harvard Medical School alumni in honor of Dr. Poussaint. The purpose of the fund is to provide an annual lecture at Harvard Medical School and a forum for connecting Harvard Medical School alumni leaders in medicine and science with Harvard Medical students, Harvard School of Dental Medicine students, with residents, with fellows, faculty across our community. Invited lecturers are typically alumni of Harvard Medical School and the programs and its teaching hospitals and research institutes. This year marks the 20th annual Poussaint Lecture and the 19th visiting lecturer. Dr. Poussaint delivered the inaugural keynote in 2005. So I want to take this opportunity to thank Dr. Selwyn Rogers, the James E. Bowman Professor of Surgery at the University of Chicago Medicine, for being here to deliver the Poussaint Lecture today. And I'm going to turn the podium back to Joan. Thank you.
Thank you for that welcome and for sharing the history of this lectureship. Just some quick notes in reviewing the disclosure forms. There were no conflicts of interest for today's presentation. Although if I could find $5 million and give them to you, you could use me as a conflict of interest disclosure that you could put up there. But that's not going to happen. For those who are attending and joining us today online, just some quick notes. The chat function is not available. Live closed captioning, however, is available, and you can turn that on. Your microphones are muted. And then we ask for the question and answer. You post them for Dr. Rogers. And at the end, please answer the poll questions before turning off. This webinar, this lectureship is being recorded and will be posted on our website. So without further ado, I want to turn to our speaker for today. After an extensive national search, Dr. Selwyn Rogers was named the section chief of trauma and acute surgery at the University of Chicago Medicine in January of 2017. And he now serves as the Dr. James E. Bowman Jr. Professor in the Biological Sciences at the University of Chicago Medicine. He's an acclaimed trauma and critical care surgeon and public health expert who has served in leadership capacities in health centers across the country, including most recently as Vice President and Chief Medical Officer for the University of Texas Medical Branch at Galveston. Dr. Rogers has also served as a chair of surgery at Temple University School of Medicine and as the division chief of trauma, burn, and surgical critical care at Harvard Medical School. While at Brigham and Women's Hospital, he helped launch the Center for Surgery and Public Health to understand the nature, quality, and utilization of surgical care nationally and internationally. He's a prolific researcher, and his work seeks to improve quality and access to care for all patients. Among other topics, he's published research, has looked at the impact of race and ethnicity on surgical outcomes. He's committed to improving the understanding of disparities in surgical care, to close the quality chasm for underserved populations, and to provide the most patient-centered care possible. Beyond trauma and surgical care, he's been an advocate for treating international violence as a public health problem. And in partnership with the Center for Community Health and Health Equity at BWH, Brigham and Women's, he developed a violence intervention and prevention program that worked to address the social factors that put patients at increased risk for trauma and mortality. Social factors such as poverty, hopelessness, and lack of opportunity. The program partners with organizations in Boston to educate youth about community violence and connects victims with the resources they need to heal. At the University of Chicago Medicine, he helped launch the Violence Recovery Program in conjunction with the Urban Health Initiative. You've been at Harvard a little bit in your career. He's has his undergraduate degree from Harvard College, magna cum laude, medical degree from Harvard Medical School, completed both his surgery residency and an NIH research fellowship in surgical oncology at Brigham and Women's Hospital, and completed surgical critical care fellowships at MGH. Additionally, he has a master's degree in public health from Vanderbilt. What I want to say, and all of these are laudable and wonderful and an amazing career and impact in medicine and science. But I want to say he's an amazing person, a kind person, a thoughtful person, and a good friend. Dr. Rogers.
May need a hand hitting the end of the show. Yep. That's it. Yeah. Oh. I need to get my slides right here.
Right there.
Thank you. You know, I'm my wife's here. I'm a little emotional because knowing the weight of this lectureship and being in the presence of Dr. Tina Poussaint, and knowing that this is the first lectureship since Dr. Poussaint's passing, it's a weight that I didn't fully anticipate. And my wife knows I'm not a very emotional person. In fact, she thinks I sometimes can be a little cold-blooded. But no, I'm very kind, as you said, Joe. So I'm going to try to muddle through a talk that shows my life's work in a set of slides. And slides don't tell the full story. And so I hope the narrative that you hear will give you a glimpse of the life that I've lived so far, very blessed to have. But when you see a turtle, according to the great Alex Haley, standing on a fence post, no turtle gets on a fence post without a lot of help. So I stand on the shoulders of many in order to be here today. So I thank those in the audience who are friends, who are colleagues, who I've worked with, mentored, been mentored by over the years. And I thank Dean Daly, thank Dr. Reed, who's been a mentor, friend, and many things in between. And Dr. Poussaint, sharing your loss, no way I could say anything more meaningful than clearly your husband was not just revered, respected, loved, but he cared about so many for so long. So thank you for how you've shared him with all of us. So Dr. Poussaint, Dr. Dean Daly did a wonderful tribute to the life of a man. Lived to be 90 years old. In many ways, you could say that people can be known by a couple things in their dash. They're born, they die, there's a dash in between. And probably the most impactful thing that people have in that dash is the people that they've touched. And for someone who has touched over 1,800 minority students who graced the halls of Harvard and gone on to do great things, his life will live on for decades, if not centuries to come, in all the legacy that he leaves behind, in addition to his wonderful family. And so I feel very honored to serve as a 19th but 20th lecturer in this series. And I hope it continues on ad infinitum. I have a couple of disclosures, and I have to do this because of the times we're in. Joan said all the nice things that could be on my obituary, but this is how I define myself. I'm an African-American male, that's obvious. I'm cisgender, which may not be obvious. I'm a birthright United States citizen, not obvious. I'm a father of 3 Black sons, something that Alvin Poussaint advocated for his entire life, the life of Black children. One of my sons is gay. I have a transgender sister. And the last one you may not know, BBDB. I know Max knows, dear friend from when he was a high school student. Born Black, died Black. And that's me in a nutshell. But that's part of what informs why I do what I do the way I do it. My lived experience I bring to my role as a doctor, as a trauma surgeon, as a man every day in every space that I walk, and I'm proud of this identity, despite what's going on at the federal level. And I think we all have to be proud of who we are in our fullest extent, despite what's going on external to us. I start with Miles, the great Miles Davis, because for those who don't know, this is probably the best album of all time, Kind of Blue. For those who don't believe in the great Miles Davis, arguably the greatest improvisational jazz musician of all time. Reinvented himself over and over again over the 50 years that he made music. Miles was also a bad dude with a lot of very cagey sayings, and this is one of my favorites of his. If you hit a wrong note, it's the next note that you play that determines if it's good or bad. And that theme runs through this talk. It's not about the note or the event. It's about what happens next. And in all of our lives, there's always something that happens next until we're dead. And I am a strong believer in redemption. I'm a strong believer in second chances. And if we gave people second chances, what are the opportunities that can come out of those second chances? And that theme runs through my talk. No story of trauma in Chicago, which is where I live, and I've lived for the past 8 years, can ignore the story of this 18-year-old Black male teenager kid. Anyone who follows basketball, like my good friend Dr. Fred Mellum knows who Benji Wilson is. Benji was arguably the Michael Jordan of his time. He was what is called a positionless player. He was 6'8", 220. He could handle the ball, so he could play point guard. He could shoot, shooting guard. He was fast, so he could play small forward. He was strong, so he could play defensive power forward. And he was able to jump through the sky and can play center. He could guard anyone, and no one can guard him. Perfect player. He, as the #1 sign as his hand shows, was going to be the #1 draft pick in the NBA in 1985. Because at the time, there was a rule that you had to go to college for at least a year before going to NBA. It was already accepted to Indiana, Illinois, DePaul. Back then, DePaul was actually good at basketball. It's been a minute since they've been good, but he had choices. But he was also a father in high school as a senior. And he and his girlfriend left school to get a bite to eat. And what should have been nothing more than a bump between two people, one person going in a store, one person leaving a store. Sorry, man, sorry we bumped into you. The person he bumped into was another 18-year-old Black male teenager having a bad day, faced with this imposing 6'8", 220-pound athlete stud of a human. And the kid was feeling threatened by Benji. And Benji said, "What are you going to do?" And that escalated like a wildfire. And the kid shot Benji Wilson twice. Once in the groin, once in the back. Benji lay bleeding on the streets of the south side of Chicago. And shortly thereafter, Chicago Fire Department brought him to a community hospital. Back then, the rule was nearest hospital, trauma, nearest hospital. But that hospital didn't have a trauma surgeon, didn't have a trauma center, didn't have blood. And he waited 4 hours, bleeding to death. We got to the operating room, and Benji Wilson died that day. That led to a rule change that if you were the most severely injured by violence or a car accident, you had to be taken to a level 1, highest level, trauma center, demarcated by age. Pediatrics, less than 16, pediatric trauma center. Above 16, adult trauma center. That became the Benji rule. because 10,000 people went to his funeral and everybody wanted to see change after his death. But his story is inextricably linked to the story of this kid on this t-shirt. It was a New York Times article from August of 2010. Damian Turner was another 18-year-old black male teenager shot and killed in Chicago from the South Side. But he too was not just another nameless teenage victim of gun violence. He was a community activist advocating for rent control and other social issues on the South Side of Chicago. And he actually was a leader, if you will, probably a natural born leader. He had created a group called Fearless Leading by the Youth. And he was shot 4 blocks from the University of Chicago, but they drove right by the University of Chicago because the University of Chicago in 1989 closed their adult trauma center. And he was transported 10 miles away to Northwestern, where he arrived dead. That too led to change because Damian wasn't just another teenager. He was a leader in his community. And that group organized around that cause of getting a trauma center somewhere in the South Side. And the trauma center in the South Side was needed because of this fact. And turns out this is an old slide from 2016, but sadly, not much has changed. You do not need to be a geospatial analytical expert like Dr. Millam to know that there's a high rate of shootings in 2 areas, South and West Chicago. Now, what's interesting is Chicago is a great American city of 77 neighborhoods. But many of us think of Chicago, the Chicago of the Cubs and the Bulls and the Bean and skyscrapers and Streeterville, some of the safest places in Chicago. But Chicago is a tale of many cities. And there's another grittier side of Chicago with disproportionate burden of unemployment, undereducation, lack of economic opportunities, high rates of unemployment, high rates of social ills that put people at risk of gun violence in particular, but other forms of structural violence like healthcare disparities. And in the context of that reality, that group that Damian Turner founded, Fearless Leading by Acute, catalyzed many community organizations to advocate for a trauma center at the University of Chicago now. And through sit-ins and die-ins and protests and blocking Michigan Ave and Mag Mile and civil disobedience, some of which was uncivil, changed the landscape of the decision not to be an adult trauma center from no, maybe, to yes, to my recruitment to serve as the inaugural founding director of the Trauma Center at the University of Chicago. A couple of things that were interesting as I learned about Chicago. Turns out many of us have been to Chicago. Probably everyone in this room, if I asked, have been through Chicago. It's a great American city, major airports. People get through there to get to many parts of the country. It's probably one of the areas of the country that there are planes, trains, and automobiles that go through routinely. And for those who have a historical bent, it's part of the Great Migration. This rural South, sharecropper times, Mississippi, Alabama, up to Chicago, Detroit, and other urban settings looking for jobs and opportunity. City of Chicago became poster child for gun violence. A poster child for gun violence and urban violence, read that Black violence, during something called the presidential election. Namely, former president at the time, current president now, Donald Trump, demonized Chicago as a place where people go to get killed. In 2016, there was a significant uptick in homicides that were 90% gun violence related, with 764 homicides that year compared to the preceding year. But the thing that's alarming to me, and should be alarming to you, is that look at the years before that. The preceding 7 years, the number of homicides in the city of Chicago never went below 400 per year. And I will tell you, because this is my area of expertise, the city of Chicago, the last time the number of homicides was less than 400 was the year that I was born, 1966. They have continually had 400 plus homicides, as high as 900 homicides during the crack epidemic in the city of Chicago, year after year after year. And the striking thing about all of that is that was happening, a third of them were happening within a 5-mile perimeter of the University of Chicago. And the University of Chicago, by the way, pays my bills, actually more importantly, pays my children's bills, phone bills, mortgage, health, healthcare, decided not to be an adult trauma center for 2 primarily public reasons. One was financial, second was capacity. I can tell you the third later. The homicide rate within the 5-mile catchment area is around East Chicago is 3 times the rest of the city of Chicago. However, Hyde Park, which is where East Chicago lives, is one of the safest neighborhoods in all of Chicago. Safest neighborhoods reinforced by over-policing by Chicago Police Department and an independent 100-member deep armed police by the University Chicago Police Department, who are commissioned Chicago Police Department officers. And if you've ever been on the campus, there are blue lights, i.e., it's almost like a perimeter. And there are sentries. If you pay attention, you'll find them. So it's actually a highly regulated environment to quote unquote make the students and faculty safe. So the absence of a trauma center on the South Side was a justice issue. Because this map, done by Dr. Hampton, one of my faculty engineer from MIT, who's faculty for the past 7 years now. In this graphic, he's very creative. Red is bad, trauma surgeon. Green is good, life. Yellow is in between. Basically, gradations of these colors represent in the 77 neighborhoods that's called Chicago, distance from a level 1 trauma center. And those in the room don't have to think about MASH or know anything about trauma to know that if you're the most severely injured and you're bleeding to death, time matters. And the quicker you can get control of bleeding, the more likely you are to survive, or the more likely you are to not lose your arm or leg if there's a gunshot wound to the extremity. And this is what things look like after the trauma center in terms of proximity to the trauma center, given the location of the University of Chicago. And like geography or real estate, it's all about location. And location for this trauma center, proximate to the South Side of Chicago, was critical. And we're currently doing some difference analyses to look at the difference that having a University of Chicago Trauma Center has meant over the past 8 years. However, I kind of knew that this was going to be hard because I'd been in 4 different level 1 trauma centers over the course of my career up until this point. I had a playbook for that, what it would take. I had experience, according to the great Jimi Hendrix. However, there are lots of things I didn't know. I never lived in Chicago. I didn't know the culture. I didn't know many people. But there's lots of things I had to learn. But these are the playbook things that I put on my certified letter of offer. These are the things that we had to do. We need a new emergency department. The old one was inadequate. We needed trauma bays. You don't need to have trauma bays if you don't have a trauma center. So those are structural things. And there was a $20 million investment to build a new emergency department. We need people. There's a lot of back and forth about how busy we're going to be. Again, geography, location. I'll come back to that in a second. So I said in my back of the envelope calculation, I think we can do it with 8. However, because of the challenge of recruiting 8 people to be part of something that had a high risk but high reward, not everyone's built for that type of risk, especially early in their career. So we started with 7, even though we're slated to be 8. And I have to make a game time decision. Are we going to go or are we going to delay? And by this time, I've been out in the community incessantly talking about May 1st, 2018. And I said, I can't disappoint. I can't fail before I even start. Orthopedic traumatologists, nighttime radiologists, training of staff. We have to develop a whole set of policies and procedures and training and education. But those are the brick and mortar of developing a trauma center. The biggest thing I had to change was culture. Peter Drucker said, culture eats strategy for breakfast. And even though I knew that, I didn't fully appreciate it until I had to change culture. I will, I know not to be metaphoric, but I will ride and die with these people. I will do anything for them at any time because they're willing to take a risk on a tall, handsome, just kidding, black guy who is willing to tell them this is a high risk, high reward opportunity that I can't guarantee success, but we're going to work our butts off to provide excellent trauma care at a place that hasn't had it for 3 decades. Everyone can see I value diversity, but not just diversity of what people look like, diversity of thought. Gary On, who was from Chicago, Ken Wilson, Grady in Atlanta, Dave Hampton, Shock Trauma Maryland, Priya Prakash, Penn, myself, Jen Cohn, LA County, Peter Bendix, Brigham Women's Hospital. Different people, different backgrounds, different experiences, all meld together to create what we love to call the East Chicago way. And it took them a while to break out. Well, at Maryland, well, at Penn, like, you're not there. Stop it. You're here now. What are we going to do together? May 1st happened. We had a 1.5 year ramp-up time to do this and those. I know everyone in this room reads it really quickly. Besides prepositions, there's only one word that appears more than once, and that word is community. I was very intentional in our mission, vision, values to make sure that everyone knew that community was front and center for this trauma center. This is a resource for the community, and to change the culture of the organization to turn towards the community as an asset, not as a liability, was foundational to the trauma center. And that's work in progress. But just the existence of the trauma center, doing it the way we have done it, has begun that pivot. So I said we start off with 7. This is what we look like now. 17 trauma faculty. And in the short past 2 years, we've trained over 10 fellows in trauma and critical care. And this is why. We were supposed to be at 3,000 a year trauma activation center. That means EMS or patient's family or the person themselves gets to walk across the threshold of the emergency department or a helicopter or the front door and be labeled a trauma, car accident, assault, gunshot wound, stabbing, fall. And that number came from back of the envelope economic calculations about how much money was the University of Chicago Medicine willing to lose on trauma patients. That's where that number came from. Now, I chuckled inside because I was like, you guys don't know what you're talking about. Because you can't turn off the spigot of a trauma center. And it's not like we're going out and recruiting patients. We're just open for business. And classic fashion, open it, build it, and they will come. We're now a 6,000 trauma activation trauma center and continuing to grow. Because as it turns out, not only was there a trauma desert on the south side of Chicago, there's also a trauma desert in Northwest Indiana. And about 10% of our patients come across the border to us because the nearest trauma center in Northwest Indiana is Indianapolis, which is 5 hours away. And sadly, this is a combination of adult and pediatrics. This is just adult, and year over year, 35 to 40% of our trauma patients have been shot. So far in Chicago, we've seen in the past 7 years, we're about to celebrate our 7th year anniversary, May 1st, so in a couple of weeks. We've seen over 32,000 trauma patients. Pretty busy. It's in the top 5% of trauma center volume. Of that 32,000, we've seen 8,000 people shot. One hospital, 8,000 people shot. And in Chicago, sadly, people don't get shot once. They get shot multiple times. And so people will have multi-compartment injuries. And we have to take care of all of that. And also, sadly, I mentioned 16 years old and below goes to the Children's Hospital. 18 to 20% of kids who are traumatically injured to our Comer Children's Hospital on the south side of Chicago, less than 16, have been shot. The youngest we've taken care of is a 1-year-old, sleeping in the bed, and everything in between. Our youngest patient has been 1, our oldest patient has been 91. And as we get into summer, you can see the seasonal variation. We see lots of trauma starting now. As the weather warms up, sadly, numbers go up. So with that knowledge, what do? We just keep on seeing people jump and be thrown into the lake or the river. See some of them drown and say that's just the way it is and do nothing else. Dr. Millen, correct me if I'm wrong, because I know you're a Chinese scholar. Was it Selwyn that said, to know and not to do is not to know? It was not Confucius, because I got called out on that once. But it's because of this fact. This is a social justice series that Dr. Poussaint committed his life to. It's because of the social determinants of health. And everyone in this room knows math. For some reason, we all have to take linear algebra and calculus in college. I don't know why that's stuff. Why does that make you a good doctor? I don't know. But this is not math. This is symbols. 85 is average life expectancy in the loop of Chicago. It's where the Hilton is, where Streeterville is, where the skyscrapers are, right? That's the beautiful part of Chicago. It's what part people see on television. 69 is average life expectancy in Washington Park, which is where my office is, overlooking Washington Park. 16 years of life lived, separated by 8 miles or 7 stops on the L train. And that's just life lived. Doesn't tell you anything about the quality of said life. And sadly, this repeats in this city too, right? So Brookline is probably between Brookline and Roxbury, a 20-year life expectancy gap. And what's driving that is not everyone's getting shot, let me be clear, it's really the social determinants of health. It's how economic stability, educational access, social and community contacts, healthcare access and quality, and the neighborhood built environment that determines these disparities. And these disparities are real people every day. And they drive health outcomes more than my ability to sew really fast. And as a trauma surgeon, we get really stoked in the middle box. Traumatic event, code trauma now, a fall, a gunshot wound. That's what gets our juices flowing. We're all adrenaline junkies. We love that, if you will, sadly, thrill. But it's not really the thrill of someone getting hurt. It's a thrill of taking that chaos and creating order out of it, making meaning out of it for the person who is injured. That's actually what the secret sauce of being a trauma surgeon is, or emergency medicine for that matter. It's about taking that chaos of a car accident or gunshot wound or intimate partner violence and creating order and meaning out of that so people can have a rehabilitated life and ideally full and complete recovery. And I don't mean physical recovery, I mean psychological, emotional, healing, so that you can be back doing what you love and want to do. But what we don't talk about is people's lived experiences and the built environment that precedes a traumatic event. And that probably is where we have lots of work to do. And by we, I mean the collectively, because this is not a problem that a health system or a hospital or trauma surgeon can solve in isolation. And the built environment where people live, work, play, pray every day is powerful. The Rand Corporation, about a decade ago, ran a campaign. If I know your zip code, I know your life expectancy. Because where you live, bike lanes, safe parks, safe housing, no lead. There's all of these things that where you live, your zip code drives. Schools, infrastructure, internet access. And in Chicago, no different. Martin Luther King Jr. back, one of the reasons why Dr. Poussaint got recruited in '69 was in '68, MLK was April 4th of '68, so not that long ago, was shot and killed, Irene Hotel. But he actually did an experiment where he brought his family, 4 kids, his wife, karate, Scott Gang that you referenced, to Chicago, to the city of Austin, the neighborhood of Austin. And after his social experiment of living in Austin, he left with this remark: Chicago is the most racist city I've ever lived in. And that segregation of the city of Chicago persists. Sadly, to this day, my wife and I go all over the city. There's lots of great restaurants, lots of places to go, lots of jazz, we're everywhere. And we'll walk in talking to each other. And then we'll sit down and people will say, are you together? No, it's not. But it's really mind-boggling, the mindset that still persists, that a Black man and a white woman can't be together. And that persists throughout the line in the city of Chicago. And literally, block by block, boulevard by boulevard, one side of a boulevard versus other in a different part of Chicago. Unemployment rate persists tragically. You can see on the south side, south side is all geography, south is below. High rates, especially if you're Black. And graduation rates also correlate as well. So they're all collinear: graduation, economic opportunities. And sadly, so there's shootings. So screen left, who are these victims of violence? Which is on the far right. But there's co-linearity with life expectancy and economic hardship. And almost if you know what economic hardship is of a community, I can tell you how many shootings there are in that same community. So now that we know, what do we do? One of the things that trauma centers can do, and over the past decade have increasingly begun to do, is to start tackling this question. If you are high risk because you've been shot and you survive the shooting, which 95% of people do, what happens next? What's the next note? This is a study from University of Maryland Shock Trauma Center, Actuarial Survival Curve, looking at people who've been shot once and only once. This is the top line versus more than once. And the reason why people die on the bottom dashed line more often is not who've been shot more than once. It's not because a second killing kills them. Right? What it's up is, yes, it's 0.95 times 0.95. That's the probability that a person going to die. But that's not 100%. The gap is the fact that the person's life has not materially changed. The same social and economic factors that drove them to be shot in the first place persist. And those same factors lead them to be higher risk for the social determinants of health that lead to increased rates of diabetes that are not managed, high rates of hypertension that's not managed, earlier strokes, heart attacks. We see 29-year-old men who happen to be Black, who otherwise think they're healthy, and they have a creatinine of 1.9, they have a blood pressure of 180 over 110, and they have glucose in their urine with a hemoglobin A1C of 12. And they didn't know they had hypertension, diabetes. It's actually funny. Some of them say, well, you gave me this disease. I'm like, no. You were walking around with it. You just didn't know it. Now we know. Let's do something about it. And it's really those other chronic mechanisms that are leading to premature mortality, not simply being shot. So these hospital-based intervention programs have been developed to wrap around services. Some of them around mental health, wellness, post-acute care, connecting people with primary care doctors. But some of it is also connecting people with community-based organizations that can address some of the social determinants of health. Some people come in and they don't know that they're entitled to get supplemental nutrition assistance program money. They don't know that they can get benefits to help them. They don't know that they can get on medication. I can't tell you how many, particularly young Black and Hispanic men, the reason why they have health insurance is that they got shot. That precipitates a set of things to get them on Medicaid, which thankfully Illinois expanded Medicaid. And our VIP program has seen over 7,000 people since we started it, concurrent with the trauma center opening. And they try to do a lot of different things and facilitated by philanthropy. Turns out I could be very convincing. I like to joke, I could sell ice to an Eskimo in January if I wanted to. But it's compelling because people can see the suffering that victims have when you make them human and you don't demonize them as the other or call them names like gangbangers. Everyone has a mother. Many of these people have children. And through the generous gift of Emily Block, who gave us $10 million to stand up our balanced recovery program, we have some sustainable funding to do this work. But it's always a struggle because what we ideally want is for it to be embedded in the budget, like any other line item. And that's work that's ongoing. And this is messy because it's not, discovering GLP-1 inhibitors, right? It's not a test tube. It's not CRISPR technology, which are all hard things. But I argue that this is harder because it's people and systems and programs and the messiness of communities and the assets of communities. And we divide our violence recovery program into two arms. One is prevention of retaliatory violence, secondary prevention, right? The ideal is never get shot in the first place. That's the ideal. We have a long way to go to get there. But for those people who are shot, how can we prevent them from being re-traumatized? And how can we prevent them and their close contacts from traumatizing others? And that's the work of street outreach, also called community violence intervention. The other arm is addressing the social determinants of violence, mental health, post-traumatic stress, the juvenile system, churches, schools. It turns out on the south side of Chicago, there are lots of assets, some of which are operating small, some of which are operating big, some of which are not to scale, some of which are. But creating aligned vectors around this work is the work of the next decade for the Trauma Center, because we have an incredible opportunity to be a convener, a Switzerland, if you will, for all these various agents that are sometimes tugging against each other. And we're trying to lead the way. There's lots of opportunity to look at novel ways to address retaliatory violence, community violence. One of them is health harming legal needs. Namely, if you're shot and you're not working, how do you pay your rent? How do you avoid getting evicted? And so we have a partnership with Chicago Legal Aid, which is pro bono legal services for victims of violence. And we are trying to fill a critical need to develop novel structural interventions to change the narrative about what happens next. And we actually got funded by NIH, and it's actually still ongoing. Fortunately, one of our partners in this is a multi-center pragmatic trial looking at providing this intervention based on availability that lawyers work 8 to 5. That's a different story. And trying to deal with some of the ecological differences of nighttime versus daytime. Obviously, most legal stuff happens during 8 to 5 hours, but trying to connect people with these services to address some of their needs and measuring the impact of the program, with the overarching goal that if it's a positive enough signal, that can be something that's embedded in level 1 trauma centers across the United States to do programs like this to meet the patient's needs. This is just one example. Unfortunately, this woman was shot by her partner in intimate partner violence. She had a premature birth of her son, and these are the social services that are already on the books that she did not know that she had access to, that Chicago Legal Aid facilitated so she can get $2,800 to meet needs that she otherwise would not have met. And for some people who are on the margins, this is the difference between being homeless with a premature birth child and being housed, having food or going hungry. And then finally, the important role of advocacy, something Dr. Poussaint was very good at through his books, through his lectures, through his voice, and giving voice to those who were voiceless. And I've been blessed to have an opportunity to do that, testifying before the Senate Judiciary Committee or the House of Representatives or any and everyone who would listen, to those who often do not have an audience. And I use that not sparingly, freely, because I can. And that extends to the written word. I love to tell my wife and my kids, I'm not violent, but I'm violent with my sword, and my sword is my pen. And when something aggravates me that I read in the press, or some figure says in the public square, I challenge them about it. This particular bothers me whenever I read about a 16-year-old man got shot in Southside Chicago. Tell me about a 16-year-old man. Who's a 16-year-old man? There's no such thing as a 16-year-old man. The way to demonize that boy. I also write about hope and gun manufacturers. I'm not the most popular guy with the NRA. And frankly, my dear, I don't give a damn. Because the price that we're paying as a society is not just to our patients, it's not just to their families, not just to the communities, it's to us, all of us. Because who do we think pays for all of this? At some level, it's our dollar being expended to provide this cure. As we know, there's no such thing as a free lunch. I also throw in there, I talk about racism. By the way, that's the third thing that was going on in Chicago. As Arnie Duncan, former Secretary of Education, said to a forum at Acute Chicago, I almost, when he said it, started doing like this. He got up at the podium, and one of the reasons why Arnie Duncan is so passionate about gun violence and youth is because he played basketball as a youth. He went to Harvard, he was a basketball captain, but when he was on the streets of Chicago, in Chicago, lots of kids that he played with all around the city were like Tayshaun. And he personally knows 5 kids that he played ball with. AAU basketball, he was all over the city trying to hone his game. And for those who play basketball, you always play against people better than you. That's how you get good or better. Isn't that right, Dr. So I'm sorry, Professor Sir Cato Lorenzo. You always play against people better than you. Basketball. So with that, for him, it's personal. And he, in a forum at Chicago, said, if this was happened to white people, we would do something differently. Now, sadly, it is happening to white people, just older white people, mostly older white men. But suicides are relatively silent and doesn't make the news the way mass shooting does. And so people's sensibilities about the fact that the #1 reason why people die by guns in the United States is self-inflicted. That is a story that's not told nearly enough. So as I close, I started with not about the note, it's about the next note. So this is the great Miles Davis. Kind of Blue, one of the best-selling, not only best-selling, but one of the best jazz albums of all time. I listen to it a lot. This actually brings me peace on a bad trauma night where for 2 minutes, I pop that in my ear. It takes me away before the pager goes off again. But in the background, in the black and white, is the other great Herbie Hancock. And I was going to leave you with these words by Herbie.
So right in the middle of Miles's solo, when he was playing one of his amazing solos, and I'm trying, I'm in there and I'm playing. Right in the middle of his solo, I played the wrong chord. A chord that it just sounded completely wrong. It sounded like a big mistake. And I did this and I went, oh, like this. And I put my hands around my ears. And Miles paused for a second. And then he played some notes that made my chord right. He made it correct, which astounded me. I couldn't believe what I heard. Miles was able to make something that was wrong into something that was right, with the power of the choice of notes that he made and the feeling that he had. And so I couldn't play for about a minute. I couldn't even touch the piano. But what I realize now is that Miles didn't hear it as a mistake. He heard it as something that happened, just an event. And so that was part of the reality of what was happening at that moment. And he dealt with it. He found something that, since he didn't hear it as a mistake, he felt it was his responsibility to find something that fit. And he was able to do that. That taught me a very big lesson about not only music, but about life. You know, we can look for the world to be as we would like it to be as individuals, you know, make it easy for me, that idea. We can look for that. But I think the important thing is that we grow. And the only way we can grow is to have a mind that's open enough to be able to accept situations, to be able to experience situations as they are and turn them into medicine, turn poison into medicine. Take whatever situation you have and make something constructive happen with it. That's what I learned from that situation with Miles.
So I challenge all of us to take whatever situation you have and make something constructive happen with it. Thank you for your time.
Thank you so much for that. Will you take comments, questions?
I prefer comments than questions.
Andrew Reed, the current director of Pharma. So
Great idea.
you made a statement that you went by really quickly, and you said that something depended on how much money University of Chicago was willing to lose. Can you speak a little bit about that?
Yeah. So,
Obviously, you lose at the beginning, where they anticipate they lose the proposition, but it's the right thing to do.
no. They had back of the envelope calculation that they would perpetually lose $20 million. So this was independent startup, right? Obviously, startup is always expected. There's a cost to startup, but there was this belief that, based on some of the erroneous assumptions, one of which no incorporation of the fact that there was this Affordable Care Act now that wasn't done. Only about 2% of our patient population leaves the hospital without being enrolled in something. The other was a lack of fundamental understanding that most people who drive cars have insurance. We are very close to the Dan Ryan. People drive faster than Dan Ryan. They come to us. And also, turns out the state of Illinois, despite being one of the lower Medicaid dollar per beneficiary, for trauma, it's one of the highest. There's a special modifier for trauma. So bottom line, there's a delta of $50 million. We make $39 million a year for the University of Chicago Medicine being a trauma center. And the more we do, the more we make. So now there's a very weird conundrum that turns out trauma provides the greatest contribution margin of all service lines, more than cancer, which is not what people predicted. So there were lots of bad assumptions.
Let me just follow that up then. One other question. So congratulations on showing them that doing the right thing actually enhanced the bottom line. You didn't mention the partnerships in terms of police and EMS. Can you speak a little bit to that? Because I know that had to be a part of this.
Yeah. So it turns out, it's. I get in trouble for what I'm about to say, so I won't say it. My wife says I can say it. So the Chicago Police Department are a bit of a gang, sadly. And EMS is actually a benefit. EMS is a facilitator. They help. And turns out in the city of Chicago, and this has to do with an interesting phenomenon. It used to be there were lots of fires in Chicago. Anyone who knows, there was a great fire caused by a cow. Not true. That never actually happened. But lots of fires. So there are lots of firefighters. But when there are all these public health changes, don't smoke in bed, fire alarms in houses, Chicago proper, you can't build a wood building during this time. Everything is brick. So if you look on the south side, for example, everything's brick. It's really expensive, but that was the retardant that was made because the whole city almost burnt down because everything was wood during the Great Fire, 1890. So with that being said, there were structural changes around fire prevention. But you still had all these firefighters and you had all these unions. So it turns out firefighter and EMS are the same. Firefighters are EMS in Chicago. So if you're like in a car accident, there's a fire truck that comes to you, get you, and an ambulance. So that being said, that's beneficent. What's not so beneficent, I'm not going to say malevolent because you can't paint a broad stroke because as I said before, I'm not a defund the police person. If someone breaks in my house, I'm calling the police. If someone breaks in my car, I'm calling, come on, give me a break. I don't have a gun. I don't carry a gun. I don't want to carry a gun ever. But we do need policing, but we need responsible policing. And there have been, in the city of Chicago in particular, decades of malfeasance by the police, decades of injustice by the police, picking up random black guys walking down the street, torturing them, and then letting them out naked, right? Just like because. And it's so bad that they've been convictions overturned after people have served 20 years just to realize the police officer made stuff up. So it's not a benign relationship that the community has with the police, which is something that has persisted. And in the midst of the Obama presidency, a consent decree that has not been implemented was declared, but it's been slow uptake. And I think of all the things the consent decree mandated on the scale of 100% in implementation, they're at 10%. So that is part of the fraught nature. And I meet with the police, but it's often a very fractious meeting, sadly. I wish it was better. In my time there have been 3 different police superintendents, 8 years. It's hard to get traction. And they've tried someone internal, they've tried people external, they're back to internal. So, and the other thing that's happened is there's been a lot of change of leadership at the mayor level. And that's also been very unstable. So to fix this in any concrete way, you really need everybody rowing together with a shared mental model. And we're doing our part, but we need so much more. Yes.
Thank you, Dr.
Thank you.
Rogers, for being here. Wyvern Osweiler, I go by Doc, because we've had
Yes.
conversations earlier today. I really honoring your statement. I'm giving you a comment that this was fantastic, and especially thinking about some of the violence prevention aspects of your work. Particularly as you were talking about like addressing the mental health components of a lot of this work. I found as a psychiatrist sometimes that like psychiatrists and surgeons aren't always like the closest bedfellows. But can you just talk
You're
about?
my buddy. Doc, you're my buddy.
But can you just talk a little bit about like what that landscape has looked like for you all in terms of getting mental health professionals and especially the psychiatrists to the table to be taking care of these young folks?
Great question. I alluded to it when we had dinner last night, I think. There are a couple of things that are going the wrong direction. The needs are great for psychiatric and mental health services and growing. Kimberly and I say all the time, we don't remember this many people with anxiety disorders when we were growing up, but it seems like everyone has an anxiety disorder. And that's not, I'm not making light of that. I'm making, 2 of my 3 kids have anxiety disorders. But I think in the context of that, the needs are great. The payment models are archaic. Cultural congruence. I'm not saying that you need to be Black to take care of a Black teenager who's been shot, but you have to be culturally dexterous, and not everyone is. And so, and then you're fighting the stigma thing. And as a child psychiatrist, the common response I get when I see evidence of post-traumatic stress disorder, like hypervigilance, looking over your shoulder, anxiety, lashing out, all very adaptive in the context of having been traumatized. The first thing people say when I say, well, you want us to get you someone with autism, there's someone, they can listen to what you have to say. And I am not crazy, right? That stigma, we have to find a better way to make people, if you will, take the medicine and don't think it's poison. And I don't mean a pill, I mean the medicine of mental health support. I contrast that of what I just said. And I remember I was in Beverly Hills just having a glass of wine after a long day. And there was a table next to me of 50-something, all white women. I didn't know at the time they were called Birkins, honey, but they probably were Birkin bags. But, expensive handbags. And you know what they're talking about? You need to go to my therapist, girlfriend. They're great. Well, that's a different culture, right? If you think this is going to help you, if you freely talk about it at a freaking bar, you think a different way about mental health. And at least in many Black communities, I can't speak for all Black people. Here's Joan. I don't speak for all Black people. But I remember my grandmother said, just pray on it. Well, prayer only gets you so far. But if your mindset is mental health means you're crazy, why would you take that up? And it takes a very brave person to change their mental model and say, going to a psychiatrist is going to help me. And I wish there were more Dr. Alvin Poussants to get that message out today. Maybe, Doc, you're going to be that person.
I have to say, one of the best and most important lectures I've heard in a very long time. Thank you very much.
Thank you.
You had a slide on the definition of the social determinants of health, which I took a picture of because I thought it was the best characterization of what that is. What do you think are the key elements? Because we're under some attack about how much time we should spend on these kinds of issues. Other people are wanting to shape our curriculum. What do you think is key to the medical education, and how has the presence of your trauma center changed the curriculum at University of Chicago?
Let me actually start with the second question first, because the first question is obviously quite, yeah. And if I could answer it, maybe I should be sitting in your chair. Not that I want your chair, just to be clear.
Careful what you wish
No,
for.
exactly. No, keep it. But
Talk to Cato.
I go back to Doc here, right? So at U Chicago, there were 3 decades of medical students who were superlative. In fact, Pritzker School of Medicine in Chicago had a track record every other year. Someone from Pritzker would come to Chicago. Could come to the Brigham for their surgical residency. I could cite you Noda, Marty Weiser. I could name them on the top of my head, right? Dave Louts. So these people I know that they went to Pritzker. I had never stopped to think that they never did a trauma rotation. It never crossed my mind. And they're great surgeons. And it never came up until I was doing this transition to Chicago. But so you had medical students who were going into medicine and surgery and psychiatry and all these fields who had no trauma exposure at all during medical school. So they started having trauma exposure, and it's become such a powerful experience for them, addressing real life social determinants of health in a very visceral way that now trauma is a mandatory rotation for all the medical students. So it's gotten embedded into the curriculum because it doesn't give them didactics about social service health. It gives them real world experience. So that's been transformative. But I go back to psychiatry. There is a third year Asian medical student. Asian probably shouldn't matter, but I'm just going to say that because he gives this incredible presentation of a complex trauma patient, no notes, and I didn't know who he was, and I thought he was an intern. And turns out he's a third year medical student. And literally, the crazy thing about this is I'm sitting next to him, hearing him talk, and we do this, try to do a little didactic back and forth thing so people actually learn something during this morning report. So you always have a teaching point or two or three. And he's hitting every point out. And I'm like, wow, I wish I was like him when I was an intern because I knew nothing. So I think I'm going to lean over and recruit him into surgery here in Chicago because one thing that I'm good at is picking talent. I can sell stuff, then I used to ask him up, but I can also pick out good talent. And I was like, this kid is going to do. So I think he's going to surgery. You know what he's going into? Psychiatry. Because he says, I want to do trauma psychiatry. I want to meet the needs of traumatized people in the field of psychiatry. And he would never have thought about that if he didn't have the exposure. So on the other side, about the bigger question, I turn that back to you because I don't have the answer to that. Yeah. We're working on it.
I want to thank you again for an amazing presentation that leaves us with a moment of a time to really to think about. Yeah, thank you. This time to really think about where we are in our country, where we are in academic medicine. And I love this concept, this idea of the next note. I think about Alvin Poussaint, whose life was always about the next note and taking what was present and in front of him and thinking about where do we go next for himself, for his patients, for the community, for the students, but this idea of a tomorrow. And so I thank you for your work. This was such a fitting presentation for this 20th Alvin Poussaint lecture. Such a fitting presentation that continues the celebration of a life well lived. And with that, would like to present you with this award, but I'm going to ask Dr. Tina Poussaint to please join us up here.
Cheers.
Right, and I do that too.
Please.
Well, good afternoon, everyone. I remember how pleased Alvin was when this lectureship was established in its name here at Harvard Medical School, featuring some of the best and brightest physicians in our world, like Dr. Rogers. Thank you, Dr. Rogers, for your outstanding talk today. It truly epitomized the values that Alvin stood for. Even when you were a medical student, he recognized you would have a soaring trajectory of success and excellence in medicine to make an impact on our world. Alvin was a gentle genius whose integrity and courage made him an advocate for excellence, justice, and equity, where he provided medical care for the civil rights workers on the Selma and Meredith marches and desegregated hospitals. And here at Harvard Medical School, recruiting and retaining outstanding medical students who have been extraordinary leaders throughout our world. Alvin's contributions and advocacy for the mental health of all of us, especially children and families, we will not forget. I knew Alvin as a kind and loving husband and father, serious and thoughtful, witty and smart, and never afraid to do what was right. To you, Dr. Joan Reed, thank you for your tireless devotion to upholding Alvin's legacy in all that you do to promote justice. To you, George, thank you for your unwavering support and recognition of Alvin and for your excellent leadership of our medical school to continue his legacy of advocacy. And to all of you, thank you for ensuring that Alvin's legacy remains alive and vibrant, never forgotten, especially in today's ever-changing world. It is a legacy we must not only remember, but actively uphold in all that we do, a guiding light for his extraordinary values. Thank you.
We're trying not to drop it, this glass.
I'm holding tight.
Thank you very much.
It's heavy. It's heavy. Again, thank you. Thank you for accepting this invitation. Thank you for inspiring all of us. Thank you for the Herbie Hancock. I just bought tickets last week. He's coming to Boston this fall.
80, still going strong.
Yes, yes. Tina, thank you for your words. Very powerful. Thank you for what you said. To all of you who are here today, where Dr. Poussaint touched each one of us in a different way, meant something, whether or not you knew him directly. There are ways in which he touched our lives. And there can be nothing better than that, than to live a life where others are touched and will carry it forward. Thank you for being with us here today. George, thank you for creating a space that celebrates the best of who we are. Thank you.
Thank you.